Hi, here we are for Intrapartum Nursing Care. What does the nurse do with all this information about the 5 Ps and the stages and how labor starts? Okay, so first we have to talk about assessment. Assessment is always the first thing you do as a nurse. So there are some routine assessments like vital signs. You're going to want to take them in active labor every 2 hours, especially their temperature if their membranes are ruptured because they're at higher risk for infection. We also use fetal monitoring, and that is a whole other set of videos. But basically, this is the way that you're going to monitor your baby. It can be continuous, which is the most common way. But there's a lot of literature that now about your normal birth, especially your first time moms, singleton babies, vertex, low risk people who actually might benefit from intermittent monitoring. And for that, you would listen every 30 minutes or every 15 minutes if it's second stage for 30 through a whole contraction and then for 30 seconds after. And you're listening to make sure that there's no decelerations of the fetal heart. And if there are, you might want to have to go back to continuous. Not for high risk women, but something to think about in the future. You might see more intermittent assessment. We used to do it in the past and then they kind of stopped it. Other assessments that you might do is a cervical exam. And I'm going to let you guys kind of feel, I have some softballs. I got some modeling clay. You take your index finger and your middle finger, sterile glove, and you're going to go gently into the vagina and reach backward until you find that cervix, and it's going to feel kind of like a bump. I have a cervical board, and that'll show you some, but it's an assessment that takes a lot of practice, and you're feeling for the dilatation. You're feeling for effacement. Effacement goes from 0 to 100%. 0 is real thick. 100% is paper thin. And then you'd kind of make a guesstimation in between. Is it 50%, 75%? It's actually kind of a good idea to let the same person do all the exams throughout labor. It's not really always feasible. But yeah, you kind of know what it felt like before, so you're going to know if there's been a change. That's a cervical exam. Other assessments you can do, you can palpate the fundus of the uterus during a contraction for contraction intensity. And for that, you want to put your hands at the top of the uterus and gently see how far you can indent it. If it feels like the tip of your nose, that's mild. If it feels like your chin, that's moderate. If it feels like your forehead, that's a strong contraction. Now, be careful if you have a mom who's got a lot of abdominal fatty tissue. Make sure you go down deep enough. Be gentle if you can, but you really have to get to the fundus of the uterus to make that assessment. And that is really, if you're using external monitoring, which most of the time you are, that's really the only way you're going to tell what the intensity of the contractions is. So that's another assessment. Now, assessment of other characteristics. When mom's water breaks, either it's going to be spontaneous rupture membranes or SROM, or it's going to be an AROM, artificial rupture membranes, also known as amniotomy. You're going to look for a few things. The first and most important thing is that you need to watch how your baby reacts to that. Because remember, one of the functions of amniotic fluid way back from week 2 was to cushion the cord. Now we might get in a situation where we have cord compression. You can even sometimes, if the baby's high enough, get cord prolapse. Okay, and that's a topic for next week. We'll talk about it, actually 2 weeks from now. So you want to watch that baby. How's that baby doing? When the water breaks, you document the time. You look at the color, amount, and you smell for the odor. Okay, so a normal rupture membranes, you should have a moderate amount, maybe 250 or 300 if you're eyeballing it. It's really not a good way to measure it. It should be clear or straw colored. If it's green, that's meconium, or brownish, that's meconium, and you need to notify some people about that, NICU, but we'll talk about that in a little bit. And you also want to note the presence of blood. Now, if it's a little blood tinge, that's one thing. Sometimes that just happens with the exam if it's an AROM, or it happens because the cervix is opening and it's got a lot of little blood vessels. If it's a small amount, if you're looking at pink tinged fluid or maybe like a little strip of mucus with some blood in it, that's okay. But if you're looking at a lot of blood, now you got to worry what's going on here. Was there an undetected previa? Is there bleeding internally, like in a subclinical abruption that we didn't know about? So you want to look for like a bloody rupture. That will tell you a lot too. And it's rare, but it can happen. Um, and you want to smell for the odor. It kind of has a fleshy smell. It's not a bad smell unless there's an infection, and then it's a terrible smell. It's a really funky, bad smell, foul smelling. So those are the things you want to document. Another way that you can tell, like say somebody says they think their water broke at home and they're coming in to be assessed for that. There are other assessments you can do. And actually the provider usually does this. They look for pooling. The first thing they do is they get a speculum and they look, is there fluid pooling in the vagina? That's called pooling. They'll see a little puddle inside the vagina. And they'll check for the presence of ferning. They'll put a swab, a sterile swab, into that fluid that's pooling, put it on a microscope slide, and under a microscope it will look like ferns, little fronds of ferns, like almost like icicles too. Weird. It's weird, but that's what ferning is. And then they can use nitrazine paper. You can use nitrazine paper too. That's not a skilled provider kind of thing. And it will turn blue because the amniotic fluid is alkaline. So those are some ways that you can tell that somebody is ruptured. And that's basically, a lot of the assessment that you're going to do is going to be your fetal monitoring. But those are some special assessments that we do in labor. Promoting physiological birth. Okay, this is super important. You want to promote things normal. That's a rebozo that she's using in this slide. Okay, and that can be used to help mom, help the baby line up. So it can be used for the passenger. If you lift the baby up and they can sort of wiggle their way into a better position and tuck their chins under. Or you can use it to take the weight of the gravid uterus off of her pelvis, and that can be like a comfort measure. So promoting physiologic birth really uses the 5 Ps. We're going to do positions that allow mom to, the pelvis or the passage to widen its diameters and accommodate that baby. We're going to do some stuff with the passenger. And that's like I said, some of these position changes will help the baby rotate into a more favorable position and align in a way where they're OA and their heads are tucked under and they're coming in straight. Okay. So we're going to work with the passenger. We're going to work with the psyche by providing continuous labor support and with pain relief. That hydrotherapy, aromatherapy, TENS units, which provide a little bit of like buzzy feeling, like stimulation. That works on gate control. If you confuse the brain with the stimulus, like in that spot where the pain was the stimulus, sometimes you relieve pain. Massage is sometimes relaxing, but you have to do it right. And counter pressure. Counter pressure works great for those OP babies, those sunny side up punks who have their hard part of their head on mom's posterior pelvis, the sacrum where all the nerves are. It's incredibly painful. So we can use counter pressure, and that's usually really helpful as well. You can use warm compresses. Just be careful of microwaving stuff because it can burn a patient. You really should only use something that's approved for you. But you'll work on the psyche and working to relieve pain. That's important. Position we've talked about, and movement. All of those things promote physiologic birth. Now we could add another P if you want to, but I hate adding things. Sometimes you just then you're just stuck counting. What's the 6th one? I don't remember. Patience. If you have patience, that's more the art of nursing. You're going to promote physiologic birth. Don't rush to intervene in an invasive way when you can do these simple physiological things that work with the 5 Ps. Labor support and non-pharmacological pain relief. I love this picture. She's in the tub. I will tell you, the tub can be a miracle for a woman who doesn't have an epidural. I've done it. I've seen patients, like their whole demeanor changes. And the next thing you know, they were 4 centimeters and now they're feeling pressure in their rectum. Okay. And that's the power of relaxation and promoting physiologic birth. Other aspects of labor support, remember, oxytocin is the hormone of love. So the rule is the mom should always have continuous labor support. But the reality of labor and delivery nursing is that it can't always be you. And a lot of times it's better when that labor support comes from someone she loves and trusts, someone whose touch she associates with comfort. And that person can be her partner, that person can be her mom, or maybe she's hired a doula and the two of them have had enough contact now that she feels safe and she's trusting. That trust and that feeling of safety, that's going to make labor go along a lot faster. And the labor support team can be an integral part of that. Of course, you're going to be in there and you're going to do a lot of it, but you're going to teach them how to do things too. And you know what? That empowers people. And I've talked to a lot of women who say, I knew my husband was a keeper that day because he would not stop rubbing my back and he never left my side. So, for us, this might be Tuesday. For her, this is a milestone event. And you kind of have to remember that. And we've already kind of discussed some of the methods of non-pharmacological relief. I want you to remember counter pressure. Counter pressure is awesome. I'm going to demonstrate it in class. Hydrotherapy is another great one. Hypnobirthing, where women enter a state of enhanced relaxation and they can actually kind of convince themselves, if they've had the training, they have to do it beforehand. You're not going to teach it to them in labor. They can actually make that area numb or even less sensitive to pain and pressure. So those are all some things we can do. Guided imagery helps. Aromatherapy helps. All of those things. The birthing ball, the peanut ball, the cub chair. In the very first slide, I don't know if you caught it, it's that inflatable blue chair. I'll point it out in class. We bought 2 for my unit, and I love them. You can use it as a birthing stool. You can use it as a position aid. And it's very comfortable. All right, venues for giving birth. We are at the end, folks. We are almost done. There are basically 3 places where most women are going to give birth. Okay, and back of an ambulance is an unexpected thing. No one ever plans that, as far as I know. Especially not the EMTs. They don't want it. But here you see a freestanding birthing center, and in the room is equipped to be homey, so it promotes that feeling of safety. There's soft lighting. Lighting is important with labor. The bright, glaring lights that were in the ceiling back in the past, that's so stressful and so not conducive to labor. You have the equipment you need. You have a birthing ball. You probably have a squat bar and or a birthing chair or stool. And there's this huge jacuzzi in the corner, and it's big enough for her support people to get in there with her. There are plants, there's nature, and that's all associated with better birth outcomes. Now, the disadvantages of birthing center, freestanding birthing center, if it's not attached to a hospital, or that if you have an emergency, you don't have as much staff, you don't have an operating room, and you might not have the kind of equipment you need. You might not have the kind of medications that can help somebody who's not able to cope with unmedicated birth. So that is a birthing center. There aren't that many. About 91% of people give birth it's 98.4% give birth in hospitals. And this is your typical labor room. We have a warmer over here with resuscitation equipment. There's a cabinet over here, and you can't see through it, but I am going to tell you that every single supply you could need in a big fat hurry is in that cabinet. Okay. If you needed an IV start kit and a line, if you need oxygen, if you need suction, if you need sutures, if you need anything aside from medications, which can't be stocked there, it's going to be in that cabinet. Even things like pads, gauze, all that stuff is going to be in there. This bed is a labor bed. It looks a lot more comfortable than the ones that I usually work with. But the thing about a labor bed is that it can be kind of taken apart and reconfigured. You can have stirrups. You can use footrests. You can take the whole bottom off the bed so that the provider can sit on a stool and deliver the baby. You can put it upright. You can put it in Trendelenburg. You can do CPR in the bed, and it does all those things. It is usually not the most comfortable thing in the world. And they're usually pretty easy to push down the hall if you need an emergency C-section. So hospitals are equipped to handle a lot of things, and that's their biggest advantage. They have the staff, they have the stuff, they have the space. Okay? The disadvantage of giving birth in a hospital is hospitals are places where sick people go to get medical treatment, and there's a medical philosophy that runs through them, including at the administration level. And so policies might be more geared toward a more medical birth routine. That having been said, midwives do practice in hospitals. And if midwives are empowered to have input and nurses are empowered to have input into policies and the way things are done, like your Better Magnet hospitals, then you might be able to promote physiologic birth a little bit easier and still have access to the life-saving things that you need. And then this last slide here, if we were going counterclockwise, is a home birth. It's a picture of home birth. And mom gave birth in a little plastic kiddie pool in her living room. And that is an option. Now, the advantages, you're not going to get all those unnecessary medical interventions. And if you have a skilled birth attendant, you have a lot more empowerment and control over your birth process. You can have all the people you love there, and you can kick them all out. It's your house. You're not going to have medical students peeking behind the curtain to see your vaginal exam. The disadvantages, of course, are that you're in a home. It can be hard to transfer that patient to an emergency setting in a big hurry. So some conditions for safe home birth: low risk only. If you're high risk and you need continuous fetal monitoring and you need magnesium sulfate, or you need Pitocin, or you need an epidural, or you're just at risk for having a bad outcome, if you're not in a hospital, you should not try giving birth at home. And a really skilled midwife who has done a lot of births and a lot of home births and has a good intuitive grasp of birth and labor, and can also kind of tell some of the behavioral cues or things from the history, should make the decision of whether or not to deliver at home. It should not be a lay midwife, or please don't get me started on free birthing. That trend has got to stop. That's your death rate from that could go up tremendously. The things that could happen, even when they don't, it would scare you if you knew. And I've seen videos of people who free birthed in their shower, and it's a 35-weeker, and he is bright blue, and she almost drops him. But she's smiling, and she's still on TikTok. I mean, and I'll tell you a story in class about a free birther on Tuesday. But this is the birth team. There's lots of players. Here we have a doula. Doulas are people. They are not medical people. They are birth experts who are trained in labor support. If you have one and she's good, and they're almost all women, I'm not trying to be exclusive here. It just seems to be what I've observed. I have never met a male doula. I have met a male midwife. I have met male labor nurses. Never met a male doula, though. A doula can provide a lot of support. She can be that continuous support person, and she's not watching the monitor, and she doesn't have to start the IV, and she doesn't have to monitor two patients at the same time. Be good to your doula. We have, of course, the family is part of the birth team. They are also instrumental. Without someone who loves you and knows you and cares about you, birth does not go as well. We have our nurses, and nurses have a lot of autonomy in labor and delivery, right? Which is great. We're the ones at the bedside. We're making a lot of minute-to-minute decisions when we're talking about normal birth. And usually the relationship between the nurses and the providers is very good because we work together closely all the time. You get to know them, they get to know you. And most of them are incredibly nice people. We have physicians, and physicians can be MDs or DOs, and they can do both. They can promote the normal. I've seen MDs who were just as caring as midwives and nurses and doulas, but they can also offer the full range of services. And about 91% of women deliver with physicians, and 9% go with midwives. And most of the time, the safest thing is to have a certified nurse midwife or a certified professional midwife. And the difference between the two is that one was a bedside nurse and, had an RN degree before they were educated, and one maybe was in another field. But If you're going with lay midwives or unskilled birth attendants, uncertified people, you're taking a big risk. But that is all I have for you for this week, this and the fetal monitoring videos, and then we will meet in class and have fun and games.